Okay, good afternoon, and my name is Jean Fajade, and really happy to be the anchor person of this special session on the robotic. You know that I am involved in robotics since close 10 years now, and I'm sure that this will be the future of interventional cardiology. It's quite a strong message I give you by starting this session, but I'm really pretty sure of that. I don't know when. It's not next week. It could be in the next month or years. But the problem we have today with interventional cardiologists are repeated problems that we repeat since 30 years. It's a problem of X-ray for the operator. Second, the problem of orthopaedic injuries for the operator after, several decades in the cathlab, standing with a leg apron, etc. But more than that, for me, the future will be coming, and we will discuss this during this session, with artificial intelligence, the machine learning, deep learning. All these things will come. And today, me, you, know what is the great expert in interventional cardiology, what is the medium, and who is the less, expert. The future will be, for me, a total equalization on the level of the operators. In other words, somebody who will have a problem of coronary artery disease, or it could be valvular disease in the future, but a problem of coronary artery disease could be treated in any country, any hospital, by any operator with quite the same, potential of effectiveness, safety of the procedures. And that's an example I took yesterday during the Innovation Day when we talk about robotics. In the military army, when you talk about fighting airplanes, they know what is the best pilot to fight the opponents and what are the medium level. When you talk about the difference of pilot in a normal airlines company, Air France, other airline of your country, you don't know if there is any difference in the pilot. Absolutely no. Whatever the weather, windy, rainy, the plane will be landing or there will be the takeoff, whatever the pilot, with exactly the same procedure. Imagine that interventional cardiology in the future will be performed with exactly the same result, efficacy, safety, whatever the hospital, the cathlab, the operator. That's, for me, it's the main goal of robotic in interventional cardiology. So, the objective of the session, so I'm not a robot, so maybe I will have some difficulty to arrange a slide. Is to understand the concept and the benefit of robotic PCI with the R1 system. Today we are here to talk about the R1 system of RoboCat, to know the tips and tricks today of robotic intervention, and to learn today how to introduce a successful robotic program in your center. So we are really lucky today to have this agenda of the session with the first recorded case presented by Michael Howley, followed by the second recorded case by Mohamed Nejari. Then Faisal Orgat will talk about learning from an early robotic adopter. And finally, after audience questions, etc., we will try to, find the take-home message of this session. But again, I'm really sure that this is the future of interventional cardiology. So, Michael.
So, Jean, Stefan, dear panelists, ladies and gentlemen, it's my pleasure to share with you two cases that we have recorded at our institution, Rheinland Klinikum in Neuss in Germany. And the two cases, if I can start it. If I like to start it.
I'm sorry.
I push the button to enter, but it doesn't do anything. Here we are. So two cases. One will be a case to be shown A to Z, and the second one will be a case to show what the Robotic PCI nowadays is capable to do in a difficult scenario. So my potential conflicts of interest. The first one will be an IVUS-guided robotic PCI.
So it's my pleasure now to introduce to you the case that we have selected for the IVUS-guided robotic PCI. It's an 83-year-old male patient who presented with stable angina class 3 according to the Canadian Cardiovascular Society, with a positive nuclear stress test and a large ischemic area infralateral. At the time of presentation, patient was troponin negative, so no acute coronary syndrome. He has a profound cardiovascular risk profile, including arterial hypertension, hypercholesterolemia, and he's an ex-smoker. In 2014, the patient received a recanalization of an RCA CTO with 5 drug-eluting stents. When we did the coronary angiography, we found a mid-left circumflex stenosis with 2 side branches originating proximal and distal to that. And you see on the right coronary angiography that there's this full metal jacketed with the 5DS within that vessel, but not stenotic. So the target clearly is the mid-left circumflex artery stenosis. So our strategy for the robotic PCI will be to use the robot to wire the main branch of that circumflex artery, do an IVUS co-registration, followed by wiring the side branches, again using the robot. Then we're going to plan the lesion preparation according to what we see on the IVUS, followed by stent implantation, IVUS control, and if necessary, post-dilatation. Now you're sitting me here in the control room of our cathlab where we plan to do the robotic PCI. Actually, you see that I don't wear a protection lead coat any longer. It's not necessary when I'm sitting here. And now it's my pleasure to present to you my workspace here. So you see that I don't have direct visual contact to the cath lab inside, so we install the camera that allows me to see what is happening in the cath lab. I have audio control with the nurse and the fellow inside the lab in order to proceed and to do the things over there. The real workstation of the robot is here. I have a console which allows me to manipulate the robot. Basically, it has 2 joysticks on the right side. This is the joystick for the wire manipulation. With this joystick, I can advance the wire, I can retract the wire, and I can torque the wire in both directions. I can do that slowly, I can do that faster, and I can do that turbo by pushing the bottom on top and advance or retract. In order to do that, I need to activate the joystick by pressing the bottom behind. On the left side, there is another joystick. This joystick is for advancing balloons, catheters, etc. Basically, you can again advance the balloons, catheters, you can retract them. You can do that slowly, you can do that very fast, and you can do that turbo way by pressing the bottom on top of it. Now, the new console has the additional option to have a millimeter stepwise advancement or retraction of the balloon. In front of me is now the monitor. The monitor covers the same parts as we do have inside the lab. I have the opportunity to have different setups to be chosen with different imaging modalities, which case-oriented I can select even during the procedure. So no difference whether I'm inside the lab or outside, I exactly see the same. And of course, what I need to do is I need to expose the X-ray from here. So I do have a foot panel in front of me that allows to both have fluoro as well as cine from the table here. And then most important, I have the opportunity to also make contrast injection via a hand contrast injector that uses an automatic injection within the lab. So I can do that from outside, from here. And finally, I have additional mouse that allows me within my monitor to work with different additional conformities, options like IVUS, etc. You see the wire at the end of the guiding catheter. Yeah, it goes better. And then we manipulate it down. So you can see I already went down for the first side branch, just to show you briefly. Yes, we are in there, but I don't want to go in with the first wire there. I want to go to the main vessel there because I want to do the IVUS pullback with co-registration first. So I retract a little bit and then move again. You see, while I'm doing that, Diana and Milad are standing behind a protection shield, so they are far away from X-ray exposure while staying in the lab there. And try to go to the main vessel, which is right now here, the case. So this is great. So I want to just show that and film that briefly, that we are in the main vessel. That's great. So you see that I advance it, goes straight through the lesion. And now I'm more or less distal to that. Good. And now the pullback is going to happen very slowly. You can see that the wire is nicely fixed in there. And now I'm back in my, we can stop the recording.
So all of these measurements are done by myself outside from the workstation. No additional personnel.
So distally, we are in the range of about 3.0. Proximally, we are in the range 3.5 to almost 4 by IVUS. So I think we're going to need to position something like a 3.0 distally that then goes up to 3.5 post-dilatation there. So I try to bend it that it looks into the circumflex artery. Yeah, it looks to the LAD. Yeah, now it looks down there, and I try to advance it slowly, and then let's see whether we can get it in one of these side branches there. So now it goes in the main branch. Try to manipulate it and try to bring it down to that second side branch. Now we need the third wire. I gently go in there. There it goes. And here we are directly into that side branch there. So now I will advance my balloon down to the lesion. Here it comes, and I try to go there, and I think that's a good spot to start with. Okay, now I make an angio. And this is what we achieved with our balloon, which is not too much. So I think we have to make a better lesion preparation before going there with the stent. So a quite rigid kind of lesion with a lot of recoil. So I will now advance the scoring balloon in order to bring it to that position. This is 15 millimeter long, 3.0 scoring. We did pre-dilate that lesion, so I think that was a 3.0 balloon. We still have some recoil, so we have to be careful with our side branch wires that they stay in place during the change maneuver. Then I advance the stent, which is at the end of the guiding catheter. It goes in now. Yeah. And now I can, on a millimeter basis, exactly position the balloon. So I will just gently give a puff. So this is actually quite fine. I will see to that. Yeah. Andrographically, the side branches are open. This is important. But according to our measurements, I think we have to upgrade the size of the stent, in particular in the mid part and the proximal portion. So I will now advance the post-dilatation balloon. And we're going to see where we have to go a little bit further, a little bit further. So here. It looks pretty nice. We have some impingement of the first side branch there, but the flow is good. So as I mentioned initially, I will not do anything on that. So angiographically, it looks quite okay. So we're going to now control and repeat our IVUS co-registration.
Again, measurements done by myself.
So I think it would be good to post-dilate with a larger balloon here in order to increase the lumen. See, it slips in there. Should be not an issue, really. And let's see where we are. Yeah, that's not too bad. So I think we can start here. And now you can see that we have significantly increased the lumen that we have achieved. Now, I think that we have achieved a fairly large lumen using a large 4.5 millimeter balloon that really opened the lumen much more. When I look at the stented segment here, there is no longer a large plug burden outside of the stent. So I think this is acceptably fine. So I think we have achieved a fairly good large lumen there. Both side branches are completely preserved. And I think this was a very nice example of a robotic PCI in a case with, if you want, two bifurcation lesions, one at the proximal end and one at the distal end. And we attempted a single device strategy. I was guided. I think it was very important to see the dimensions in order to achieve an adequate lumen. We need to use large balloons here at the end. With respect to the robotic appearance and usage here, it was important to appreciate that we worked here with 3 different wires, 1 working wire in the main vessel and 2 side branch wires, proximal and distal, all manipulated by the robot. They were easily to steer, and it was really easy to bring them down there. Honestly speaking, I wouldn't have expected that to be as easy as it appeared to be. Now, having said that, I think we're done with that case. I want to thank the whole team here for collaborating in this important presentation, and therefore we're going to finish right now. Thank you.
So this. Thank you very much, but it was a bit too early. I have a second case. The short one, I will not escape that from you. A case which is, just to make that briefly short, a very, very tortuous right coronary artery and very calcified. Because when we magnify this a little bit, there is a focal lesion in the proximal right and there is an additional lesion in the mid right, eccentric. And at that time, we attempted IVUS and we were not able to pass with the IVUS through the proximal lesion. So we put the challenge to the robotic PCI to make that procedure via a robotic approach. And this is what I like to show you. The attempt was to wire the RCA by the robot, to advance via the robot an IVL catheter to do lithotripsy in order to make an adequate lesion preparation. If this is not possible, we need to predilate, retry IVL, again, all done via the robot, post-dilate, stent implantation, and post-dilate if necessary. So all steps have been completed successfully by the robot, but I will give you a little excerpt of what we have achieved. The first thing is the wire manipulation through that tortuous vessel, calcified vessel. This is real time, what you're going to see right now. So the wire went down quite easily. When you do these things with the robot, you experience some ways of pre-shaping your wire according to different conditions in the artery. That is important. But here you can see it was quite easy. So I go very distal to have maximum support, because then next step is to bring forward the IVL catheter, which you are aware of, is somewhat more bulky. And this is now the IVL catheter, pushed forward by the robot. And you can see the IVUS didn't pass manually, but the robot brought the IVL catheter over the two lesions to the very distal lesion. And I just want to show you the very end, after being treated with, at the end, two stents, one proximal, one distal, with that kind of result. We used the new IVL catheter with 120 pulses, put 80 on the distal lesion and 40 on the proximal lesion for lesion preparation, and that was the result of, again, a fully robotic PCI procedure. Showing that and having said that, I thank you very much for your kind attention.
Thank you, Michael, and I'm sure that there are some questions from the audience. Do not hesitate to have some microphone in the medium alley, or you can use the application. We have coming application. Stefan.
A wonderful demonstration, Michael, and you mentioned that this is actually what you see is real time. So one of the questions is, how long does the procedure take for you? I mean, when you're looking at it, it looks fairly easy, but of course we don't see the steps in between. So could you perhaps comment on this?
It's depending, of course, on the complexity, on the amount of changing of catheters that is going to enhance, because the changing of catheters is and devices is taking somewhat more time than when you do it manually. Honestly speaking, for the first procedure, I would like to say it's about 20% longer than I would have done it manually, or if I would have done it manually. With this one here, honestly speaking, I'm more or less on the same time level, because I don't think that I would have been much faster with wiring this tortuous vessel, and to push forward the catheter, well, a second less or more doesn't play any role.
But I think it also comes down to the learning curve. What is your experience in terms of doing cases, and how fast do you feel confident to say I'm leave it over to the robotic interventional?
I think it's an important question. It depends on how affine you are with playing with joysticks. I mean, we are all belonging to that first generation of joystick games we had in the 90s, early 2000s, and played with that. I think the modern generation, youngest generation, with all their PlayStations that they have around, they have a dedicated, very short learning curve in order to know what to do with the joystick in order to orient the wire. I mean, the big difference is that you have no tactile feedback. You only rely on what you see and then correct. This is something, at the moment, your brain thinks it's strange. At the end of the story, it's very easily doable.
Francisco, you have a comment?
Yeah, I saw that in both cases you use amplathless guiding catheter. Do you think that we need, when you do a robotic PCI, we need always higher support to avoid to manipulate guiding catheter and to use only the wire and balloon?
Very important question again, and honestly speaking, in general, I focus very much to have a very stable guiding support anyway. When I do a robotic PCI, I will have attempt for a super stable guiding position, because when the guide wire pops out, I need to go back in and recorrect it. That's also the reason why I'm doing that by myself and not do that the fellow. I want to know when I bring in that guiding catheter, how stable is that really? Because sometimes, in particular for that second case here with this Tortuous right coronary artery, you need to have some push, and the least thing you would like to have is that your ambulance catheter pops out, because then for sure you need to reposition, which you cannot do by the robot.
Select. Stefan.
Yeah, I'd like to have or comments from the panel. There are some experts here, and one of the questions is, what about the guiding? Can you adjust or manipulate the guiding? And what happens if sometimes it occurs that the guiding just takes a deep dive into the artery? So how do you adjust for that? Do you have any comments on that?
Yeah. So first I must say that I have not changed my selection of guiding catheters. I continue to do what I always did. But yes, I do pay additional attention to guiding catheter stability. And I have a low threshold to use a body wire, for example, to improve stability of the catheter.
I have the same practice. I select the same guiding catheter with procedure manually, but the support is very important for robotic also. So you have to choose the good guiding catheter to have a good support.
Stefan, if the catheter deep dives, I mean, you do the same thing that you regularly would try to do. You try to advance your wire and try to push by that your guiding catheter back. Whether you do that manually or whether the robot is going to do that, for me, doesn't make a significant difference.
It's true that sometimes when we have a difficult procedure and we do this manually, sometimes we have to intubate the vessel, the proximal part of the vessel, with a guiding catheter on the balloon, for example. And so you push your guiding catheter inside the vessel in order to have a better support. At present time, this is not possible to do because we have not a joystick for the guiding catheter. But I know that the next generation will come with the joystick. And so we could do with the two joystick, advancing the guiding catheter, removing the balloon, and so we will get the better support.
Quick question in terms of contrast use. Is there a difference? Do we use less contrast? Do we use more contrast? What is your take on that? Francesco, perhaps?
Well, our experience now is limited. I don't think we did some difference in terms of the quantity of contrast used if you do manual or robotic PCI. So I don't think it's the main difference in this thing.
And then another question here that is important and that comes up very regularly is basically what happens in case of emergency. What if you have a perforation? What if there is a major dissection? How do you easily convert, or do you need to convert to a manual operation? Any comments from the panel? So,
in our lab, we have not yet transitioned to being out in the control room. So I'm seated quite close to the patient and I'm still leaded. It's straightforward. You just unclip the TUI boards from the robotic system and continue as if you would do a normal procedure. I'll show you some data. Thankfully, we haven't had any major complications like that to date.
Yeah, the conversion is very fast because the nurse, when you train your team and your nurse, the conversion manually it's very fast, and the advantage of the robot is the stability of the wire, stability of guiding catheter. So if you have emergency like dissection or other, you can very easy to convert.
Thank you. Unfortunately, it's time, it's time to move to the next presentation. Thank you, Michael. It was superb demonstration of what we can do using the robotic. And now it's my pleasure to invite Mohamed Dejari from the CCN Saint-Denis Paris to present the second recorded case.
Good afternoon. It's a pleasure for me to present to you this second case done by myself and Thibaut Coquelets, my nurse. So it's the case of 59 years old man at high risk admitted in our institution for acute coronary syndrome with elevation of troponin. Clinical exam, EKG, lab tests were normal. The LV function was also normal, and the TTE showed a lateral hypokinesia. As you can see here, the angio, you have a long lesion with a severe stenosis of a circumflex and marginal, an intermediate lesion on the proximal LAD, and finally a short and tight lesion on the distal part of RCA. So our decision of revascularization in this quite young man with acute coronary syndrome with multivessel disease is to perform PCI by robotic approach, beginning by LAD lesion assessment by FFR, and after that PCI on circumflex and marginal and distal part of RCA in the same procedure. We did this procedure by radial access. My nurse in the cathlab to manage the robot, and myself in the control room to do the procedure.
Before starting the robotic procedure, the nurse installs the cassette on the robotic unit. This cassette has a sterile strap that covers all the robotic arm fixed at the table. An auto test is run to check the position of the cassette on the robot. Now the nurse is moving the robotic unit to position it in front of the puncture site. He connects the Y connector to the distal end of the robot, and then shapes the FFR wire under my instruction and introduces it into the guiding catheter. The proximal part of the wire is then quickly locked in the robot. As you can see, I'm now advancing the FFR wire into the LAD. I manipulate the wire as I will do by hands, combining rotation and translation to drill it and avoid side branches to go straight forward into the vessel. As you can see, FFR on LAD lesion is negative. Now I quickly remove robotically the FFR wire from the LAD, and Thibaut removes the FFR wire from the robot. Here, under my control and my instruction, Thibaut positions the guiding catheter, which extubated a little bit. Here the communication is key between the physician and the nurse to avoid any safety issue. Then he connects again the Y connector to the robot and introduces the wire. I manipulate now the wire into the circumflex artery. At the distal part, the lesion is very tight, so we need to manipulate the wire very gently to avoid any dissection. With a combination of rotation and retraction movement, the wire goes straight forward into the main branch. Now, the nurse introduces the balloon on the wire and then advances it with precaution to maintain the wire in position and locked it into the robot. Then I advance the balloon, first in turbo mode into the guiding and then slowly into the circumflex until the lesion. Thanks to robotic precision, I can position very precisely the balloon. Now we can start to predilate the lesion. This is the only step of the procedure when the nurse needs to be near the patient and the X-ray tube. Then I control by an angio to assess the side branch and the lesion to choose the stent length, and I remove the balloon robotically and manually by Thibaut. Now Thibaut loads the first stent to cover the distal lesion. I then advance the stent millimeter by millimeter. During inflation or contrast injection, for which Thibaut is in charge, it's particularly important to have a perfect audio communication and to have a precise language. Now I retract the stent robotically, and then the nurse removes it again, paying attention to maintain the wire in place. Now we decide to place a second stent, paying attention to minimize the overlapping. This is a perfect example of how you can combine smart tools with, on one side, the new robotic millimetric mode to position very precisely the stent, and on the other side, the stent boost technology. Thibaut now inflates the stent under my instruction. Then I push the balloon to post-dilate the transition of the two stents. I now remove the balloon and the wire before the final angio, and as you can see, the result is good. The nurse disconnects the robot and I position my Jenkins Wright guiding catheter in the right coronary artery. While I'm going back into the control room, Thibaut connects the robot to the Y connector again. As you can see, the transition is very smooth. I now advance the wire into the RCA. As you can see, while I'm navigating, Thibaut stands behind a radio protection screen, so he takes no radiation and injects contrast when I'm asking for. The wire is now in the distal part of the vessel, and we decide to advance the stent without predilatation, and the progression is very smooth without any resistance. Now we place the stent precisely and the nurse inflates it under my clear instruction. As you can see, this is a perfect result, and I can now remove the balloon and the wire. Thanks to the whole team for this great robotic case, and thank you all.
So the take-home message of this case, as you can see, the robotic PCI was safe and effective in multi-vessel disease cases. The FFR lesion assessment is feasible and effective by robotic approach. The robotic provides some advantage, precise and safe wiring, accurate stent positioning to avoid any overlapping, and finally, full radio protection and comfort for the operator. I have some tips and tricks to begin a robotic program. Training is key. The organization and the communication in the cathlab is very important with using a precise and same language. And finally, this robotic program allows to improve skills, the nurse skills and autonomy. Thank you for your attention.
Thank you, Mohamed. Any question? Stefan, you have from the app?
Not from the app, actually, but I do have a question for you, Jean. You have such a vast experience, and you have educated so many fellows and interventional cardiologists in your career, and you talked about the future of robotic PCI. How do you envision the training of fellows in the future in terms of they don't have, if they go for robotic PCI, they may not have the tactile feeling of what we do, of what we have been doing. So how do you foresee the future in terms of education and training fellows and new interventional cardiologists?
It's a good question because, of course, training education is part of our job in order to train a new generation of interventional cardiologists. And it's true that via the robot, we have a better possibility to train not only one fellow but two fellows on the same lesion, on the same patient. So the second is the facility to learn. I was really impressed when I started my experience. It was with the Tortuous robot, and at the end I was more than 200 procedures performed. But it was fantastic to, feel. In fact, no feeling, because via the joystick you have no feeling, and that's the main difference. And the seat is the same for our fellows. In other words, when you do perform a procedure manually, you follow, for example, your wire on the screen, and you have the tactile sensation, the tactile feeling of the wire. And so when you see the wire, the distality of the wire kinking like that, you know that you feel it first, the resistance of the vessel wall, and immediately, of course, the reaction is to remove a little bit and then retry. Here with the robot, we do not feel this. So in fact, we have just what you see on the screen, and to adapt to what you see on the screen, the reaction with the joystick. So how many procedures do we need to move from this visual, manual, and only the visual way to perform the procedure? What I will say, 10, 15 procedures done. For a standard interventional cardiologist who is working in the cath lab every day. Because we, in fact, transmit via robotic system what we have learned manually since years. Difficult to explain, but it's like that. For a young generation, we have less experience manually. I think that they will move in the future very quickly in the robotic procedure. In other words, it's the young generation is on this kind of device all the day. It's not my case because I'm quite old now, but this kind of generation, well, playing on the device application of the day, will move on robotic device very easily. For me, there is no major question on that.
May I comment? Sorry, I'll be provocative. I actually think that the tactile feedback is exaggerated. I think when I first used R1, on my very first case, I was able to perform an angioplasty on an animal model with a zero learning curve. And the reason for that is I'd done many procedures with the Hansen system where there was no tactile feedback. In fact, we had the option for tactile feedback with the Hansen system. You know, if anybody's interested, I can explain it at some other time, but there was an option on the Hansen system where we could feel what the catheter was doing, but we switched it off. We didn't need it. We just found it slowed us down.
So I understand what you say, but again, I'm not issued from the same generation. In other words, when we start in cardiology, we have a really poor profile device, etc. And I can tell you, we failed. Second is the type of wire that you use.
Yes.
If you use hydrophilic wire, Sion wire, what you want, effectively, you have no tactile. Me, I still use a BMW wire for 99% of the procedure. So, and you feel it. Yes. And it's why I like this kind of old wires, because you feel something. That's the difference.
Well, I think we have an early adapter here in the room, and the next presentation is actually by Faisal. So we're all very keen to hear what you will learn about your experience, Faisal.
Thank you.
Dr. Ferjede, Stefan, thank you for inviting me. I'm very honored. So I have no disclosures I've worked closely with both Hansen and Robocath, but have not received any financial return for it, so I have no conflicts to declare. So my robotic experience started a long time back, in fact in 2009, with the Hansen system. So the Hansen system was designed and optimized to manage ablation catheters. So it's very similar in design in that there is a robotic manipulator, a control panel, and a disposable flexible sheath which was open platform and which housed the ablation catheter. Our control panel was installed out in the control room with the technicians. Between 2009 and 2017, I performed 1,600 robotic procedures, predominantly AF and flutter. So what we found with the robotic system is that the more complex the procedure, the more benefit we got from the robotic system. Consider this. We calculated that I protected my body from approximately 200 hours of X-ray radiation. If you were to estimate roughly between 5 and 10 minutes of fluoroscopy for any one AF ablation, so that's something to consider. Imagine what a cardiologist gets exposed to in a lifetime of doing angioplasty. We also learned from the Hansen system that the device was unbelievably precise and fast. And the more we used it, the faster we became. I could do an AF ablation in 45 minutes. Only now, almost a decade later, with newer technologies like contact sensing and high power, short duration, am I beginning to achieve those times again. we've addressed the visual versus tactile feedback issue, and so I won't dwell on it too much. So let's move on. So I first saw the R1 device in 2019. And of course, having experienced Hansen, I was very excited and enthusiastic about the R1. Unfortunately, COVID came along and we lost a lot of time. But nevertheless, we got a program started in Cape Town. Initially, we did 21 patients just to get a feel for the system. And we prospectively collected the data. And an important observation is that we had absolutely no complications at 1 month and 6 months. And we did push the system. We did find a few issues with the initial iteration, but after a few minor tweaks, I was convinced that the system was ready for prime time. So we started a formal study. We've already done 40 patients. This is an ethics-approved safety and feasibility study, in some ways similar to the R1, the R evolution study, except I think our patient cohort is a little more complex, or significantly more complex. I'm pleased to say that 85% of access was distal radial. As you can see from the slide, we have a fair distribution of vessels. We also included, for example, a left main stem, although it was a protected left main stem. One of our patients required lithotripsy, which we also did completely robotically. About 29 of our patients required predilation. 34 required post-dilation. These were mostly type B lesions. We had 100% clinical success. No crossovers to manual at all. And again, at 1 month, we had no major adverse complications. One patient did come back with heart failure. We recathed the patient, and the stent was widely patent. Patient settled with medical therapy. The question was asked about whether it prolongs procedure time. Look at our average procedure time was 39 minutes. And as different to the R1 evolution study, we're reporting procedure times from the moment we start the cassette. Once we apply the cassette to the R1 device, we start the clock. So considering the complexity of the patients we dealt with, I think 39 minutes is reasonable. So I think my time is up, and I think maybe the data speaks for itself. So I'll just summarize by saying, I have no doubt that robotic angioplasty is safe, efficient, protects the operator, and is definitely the future. Thank you.
Thank you, Faisal. That was fantastic. Now, you as an early adapter, how would you predict the future? And what is, of course, we'll talk about robotic PCI, but you can ask and argue, is it really robotic? And then comes the AI into play. So where do you see yourself in 5 to 10 years from now, when you integrate, like Jean already alluded to, is deep learning and AI and all that kind of stuff? How do you see that yourself for the next procedures?
Well, I think I'll be sitting here, and we'll be instructing the R1 device in Cape Town to do the angioplasty. And in fact, when I need my angioplasty, I'm going to ask Dr. Fagidet to do it from Paris. That's where we will be.
I hope that the line will not be cut.
No, I think Elon Musk is taking care of that with all his satellites.
And a protest in France or something like that. Yeah.
Thank you very much, Faisal. If there are no any further questions from the audience, then I would like to ask Jean to put the key learnings and conclude the session.
Come on, Sarah.
Okay, so now, unfortunately, it's time to conclude, but we could talk hours on and discuss hours of this fantastic technology. And what I will say, so we very fast, we know from all the presentation that it's an effective procedure, it's safe. And what is interesting is the compatibility with intravascular imaging device and IV and some device like IVL or laser. The benefit for the patient, for me, is a precision in the positioning, for example, of the stent, particularly when you want to position at the ostium, for example, of a vessel. It's extremely stable, and the precision is really optimal. The benefit, of course, we talk about the X-ray exposure and the orthopaedic injuries for the lady prone for all the team. And it's true that the training is fundamental, but it will be helped by this technology. The perspective to facilitate a wider, use of and dissemination of robotic procedure, we need, of course, some technical improvement, and the RoboCat company know that, and the possibility to have a simultaneous manipulation of the two wires, two balloons, two stents. This we need particularly for complex bifurcation lesion. The over-the-wire compatibility with the different system, and the full integration in the cathlab. The future, what I tell you, is really bright for this technology, and particularly the second line is the partial automation using machine learning and artificial intelligence. It's really the field for the future. It's so wide. It's really impressive to believe what we could do in the next decade. And I think that this is my final slide. Today we are here using all this technology manually. The robot is coming, but the future will be there. The future will be, we could believe in a special cathlab center by the robotic system, and connected with the different system devices in imaging, physiology, all the type of device to treat the lesion, and in the same time connected with this artificial intelligence, the data collection, the machine learning, and at the end, the robotic will be at the center of the cathlab. The operator, like you, like me, will be there to look at if everything is going well. But really, it's a brilliant future. My last sentence will be, in the last now close 40 years in interventional cardiology, we had a lot of, improvement. There was a balloon, the stent, etc., etc. Each time there was something new, the DES, etc. But it was, the same intervention with new devices, but the same intervention. Here, we move from, the old system, the old period, to something totally new, and we will see. I'm sure that we will have more and more in the next year session to discuss this. Michael nowadays is smiling, but I'm really sure of that. And so the room is full. There is a reason for that. And I would like to thank you. We are on time. I wish you a nice meeting. And if you have time, take the time to visit the stand of RoboCat. You will have the possibility to see the robot itself, and I think to use it. Okay, thank you very much. Have a nice day.